Well, thank you very much for that kind introduction, and let me also thank the organizers for the invitation. Dr. Phillips, thank you. A particular thanks, actually, for it's always a nice opportunity to get out of my regular role as Vice President at U of T and Principal at UT Scarborough, so it's a particular delight to actually talk about science and be here with you today. The organizers asked me to focus my talk on the biological end of the spectrum with respect to therapies, and so I'm going to spend my time really talking about pharmacotherapies and then end it with this new and emerging area, the use of vaccines in the treatment of addiction. So I'd like to cover four topics today. The first is really addiction process and brain pathways, relevance to pharmacotherapy targets. We've heard a little bit about that, actually quite a bit about that today from both Dr. Layton and Dr. Phillips. I'm going to mention those points again here because both implicitly and explicitly, I think they're very much related to the strategy that has been taken for the development of current pharmacotherapy. So it's an important backdrop for that. Talk a little bit about the current state of affairs with pharmacotherapies, new and emerging, and that's the immunotherapies, and future directions and final thoughts. So first of all, we've heard a fair amount of this today. Addiction is a brain disorder. Like mental illness, it's a brain disease. It's not just a brain disease. Because of its nature and the lateral implications of this particular disorder, there's social issues, there's population issues, there's policy issues, but it is that. It's characterized by compulsive and at times uncontrollable craving and drug seeking. And the key point here is that these behaviors stem from drug-induced changes in brain structures and function. And it's also of note that these changes occur in some of the same areas that are disrupted in other mental disorders, and that's important to remember because in the clinical reality for physicians and other health workers dealing with addiction is that more often than not these individuals have not only addictions but also other mental health challenges, and that neuroanatomical coincidence is particularly relevant in that context. But the final bullet there is the neuroscience of addiction has provided a platform for pharmacotherapy developments related to addiction treatment. So this is just a reminder that it's particularly challenging when we talk about pharmacotherapies in addiction because the target culprit in some ways is a drug, and the medication that is being developed is also a drug. And sometimes the medication and the culprit, the drug of abuse, if you will share some of the same features. And this is just a reminder of that. His Holiness Pope Leo XIII actually carried a hip flask to fortify himself in need. And what the concoction was something that Angelo Mariani, who was a pharmacist, a Corsican pharmacist, actually developed. It was a combination of wine and cocaine. And so every once in a while, the Pope would fortify himself with it. And not only was it perfectly okay, in fact, the celebrity endorsement that was triggered by Mariani just underlines the different place we were at in those days. The nature of this brain-based disorder is a motivational disorder, and we've heard about this both again from Marco and Tony. And we've heard the word hijack, and that's an excellent word because what happens in individuals in the full expression of addiction is a true hijacking of the motivational system. If you think about the things that are important in our lives, we have an implicit rank order. And that rank order is bypassed, is hijacked, if you will, in the addiction process, where the drug takes a primary or has primacy in that rank ordering of things that are important. And in many ways, that's the hallmark of addiction. So motivational systems, our ability to make choices and direct our behavior towards those things, those goals that are important to us, is severely disrupted, following short, but in particular, long-term exposure to drugs of abuse. This is captured in this bullet. It says, Susan, this might just be the wine talking, but I think I want to order more wine. So these alterations are at the core of brain dysfunction, and the thing to keep in mind, and again, it's something that's been noted, is that these alterations can be caused by drug use itself directly, so the drugs themselves having a direct effect on these biological systems in the brain, but environmental factors as well. We've talked about externally derived stress, for example, and more extreme neurobiological conditions like mental illness can actually also impact on the activity of these brain regions. So a big question that you've heard a little bit about today is the question of a common pathway for different drugs of abuse. And this has been a question, and the reason I raise it here is because the answer to that, if there is a common pathway or not, has a significant influence on the strategy towards drug development. If there's a common pathway such that different drugs of abuse converge onto a common pathway, that is going to have a dramatic effect on drug development strategies, that knowledge. If the answer is, well, no, each drug of abuse has its own kind of parallel or independent pathway, that's going to have significant influence on development strategy. Well, you already know the answers to that question. The mesolimbic dopamine system is an area of focus. And I'm going to simplify. I mean, there are thousands and thousands of papers relating to the neurochemistry of addiction, but I would argue that the one common converging reality is that this mesolimbic dopamine system really represents very much a common denominator for different drugs of abuse in terms of their rewarding properties. They converge on this system. And this is just another way of making this point. This shows you the distribution of cocaine receptor sites. That central purple area there is the mesolimbic dopamine system, ventral tegmental area to nucleus accumbens. These are opiates, and this is tetrahydrocannabinol, the active ingredient in cannabinoids. And the point that I'd be making in this is that, of course, these drugs are different. They have different behavioral characteristics. However, they all share the common property of having dependence-producing elements associated with them. And the notion, of course, is that mesolimbic dopamine system is the biological basis for that one common property, and the other elements of these drugs in terms of their effects dissociates them behaviorally, but that common mechanism is underlied by their rewarding properties. Now, dependence, of course, is much more than drug reward. When we think about drug reward, we think of approach behavior, hedonic reactivity. We're attracted to things that we like, and so we approach them. We assign positive valence to stimuli, to situations and environments that are associated with them. And this is linked to conditioning and sensitization that we've heard about. The long-term effects, which are in many ways the effects that are actually associated with the full expression of addiction, are not only different, in some cases they're almost opposite. So you have maladaptive reward functioning, you have anticipatory arousal, there's significant anxiety that is precipitated, relapse craving, sensitivity to drug-related cues, exaggerated mental preoccupation, tolerance withdrawal. These are longer-term effects. So I want to just highlight something that Marco highlighted, and it has to do with imaging studies. This one says, why on earth would you spring for color film? By the way, I showed this to a younger audience. They had no idea what this slide was about. He said, what does this mean? This is saying, also when I say if we fast forward, they kind of look at me in a funny way because we don't fast forward anymore. Addiction-linked brain changes in people. We've seen these results from Marco's presentation, so he's already sensitized the group here. But I'll just stress the point again. It makes 2 points. One is that the actual direction of the changes in dopaminergic abnormalities in the case of full-fledged addiction is actually in the opposite direction of the rewarding properties. Rewarding properties are associated with the activation of these reward systems and dopamine in particular. The long-term effects are actually associated with the down-regulation. It's really an adaptive biological response to the long-term driving of this system, and it's expressed as a down-regulation in the receptors. And you can see it, as has already been shown, in these different drug classes. Now, why do I mention this? Well, I mention it because it's a reminder of of the importance of thinking about the various stages associated with addiction in relation to biological and in particular pharmacological interventions and pharmacotherapy development strategies. So if we think about the mechanisms underlying the early phases of the addiction process, the front end, if you will, and we've heard about this today, the initiation, reward systems, and sensitization, those are quite different from what evolves and what emerges in the mid stages and the later stages. Reinforcement and conditioning processes is kind of the mid stages, and the later stages of drug dependence associated with almost this reversal, a down-regulation of the system, a compensatory adaptation to the long-term hyperactivating situation with the dopamine neurons. The focus of current pharmacotherapies is largely at the later stages. And I think it's something to keep in the back of our minds when we think about, we know quite a bit regarding the mechanisms underlying these different stages, but there is at some level a disconnect between the sophistication or the resolution of that kind of information that we have and the level at which we're testing the clinical in the clinical context and trials. So although the early and mid stages are very, very important, if we could intervene at those stages, arguably you could see some very interesting and important effects. Most of the pharmacotherapies, the typical focus is later stages. And the sub-bullets at the very end are just highlighting the different kinds of approaches at those later stages. So there's what I would call extinction-based approach, the idea of having medications that antagonize, that actually block the effects of the drug, with the ultimate goal, in many cases in a medical context, of actually extinguishing the behavior. Then there are substitution-based approaches that target agonists or partial agonists, and the idea there is to mimic the effects of the drug to a certain extent without having the full addictive potential. There's also treatments that target craving and affect related systems. There's also aversion-based approaches like disulfiram, which is creating an extreme aversive reaction to drug intake, almost a punishment-based system, and then withdrawal management. So what I'm going to do is I'm going to go through each of these fairly quickly, just to give you a bit of a snapshot of where the field's at, and both in relation to where we're at today and what are the innovations in that field. These are I've talked in the previous slide about process-related targets, early, mid, late. These are neurochemical targets for both past and recent treatments. Nicotininergic receptors associated with the acetylcholine system, GABA, NMDA receptors linked to glutamate, and I would add AMPA receptors to that, serotonin, dopamine, and opiates. Now what you'll notice is that only the dopamine and the opioid-based treatments are actually directly, these are treatments that are directly accessing the systems that the drugs are at a first order affecting. The other systems, for the most part, are systems that either directly or indirectly will impact on dopaminergic and opioid systems, and have also been looked at. What I've tried to do here, don't worry about the nuances here, but it's basically just a reminder that these neurochemical systems that I've just mentioned, the reason that these systems have become targets is because there is there's the rationale behind them is their linkages and the neurochemical anatomy that shows that's depicted here, where if this is the mesolimbic system, and these various transmitters in one way or another impact on this system. So either implicitly or explicitly, the rationale for many behind much of the pharmacotherapeutic developments is based on this kind of neuroscientific knowledge. So let's start the first snapshot, dopamine agonist-based treatments. And the idea here is to increase dopaminergic activity in order to reduce the harm and weaken the addiction. The goal is to reduce the strength of the craving and as well as the withdrawal symptoms. And these are 3 examples of medications that are used. And what I've done also here is I've approximated the year that these medications more or less were initially looked at as possible treatments and tested in humans. And I'm doing that to give you a sense of where the field's at and what are the most recent developments. Okay. So, and this is just one example of bupropion showing some modest efficacy in alcohol abstinence. These are nicotininergic systems. And what we can see here, this is in the case of cigarette and craving. And again, you can see that there is some modest, I would say modest to moderate efficacy, and that's going to be a theme in much of this. Pharmacological treatments targeting opioid systems. We have methadone, which has been with us since the 60s and in many ways is a standard, and more recently buprenorphine and Suboxone, which is a mixture of buprenorphine and naloxone, and that's available in Canada. Buprenorphine alone is not available in Canada, it's only available in the US. Again, you don't have to look at the details of this, but what you see in each of these cases is what I would call modest efficacy in terms of impact. I do want to get to the immunotherapy point, and I've just been given a couple of minutes here. So this is just a reminder of the emerging glutamate-related treatments, and here are some of them here. Acamprosate is one on the NMDA system, and topiramate in an AMPA antagonist. Again, highlighting GABA, glutamate systems, which I think is one of the more recent innovative areas here. And here's an example of an NMDA blocker effect, percent without relapse, and this is in an alcohol situation. And you can see that the acamprosate group, there was about a 20 or 30% advantage over naloxone in this particular case. Clonidine, it's a withdrawal management based system and really used to alleviate withdrawal symptoms associated with detoxification. Disulfiram, I've mentioned, an aversion-based treatment that is, the aversiveness is related to the increase in acetaldehyde formation caused by this enzymatic blockade, and that creates a very intense aversive reaction, and recently found to also have potential association with the dopamine system. New and emerging. You could publish in Science, but The Economist is where you know you've made it when you're in The Economist. So this is in 2011. The Economist picked up on this: combating addiction, can a vaccine stop drug abuse? So the notion here is immunotherapy approach aims to create vaccines that allow the immune system to recognize the drug molecule and create an immune response. So the idea is to immunize against a particular drug class. The immune response would be characterized by inactivation of the drug effect and a remembering, if you will, by the immune system. And this is just making this point. You could see, in theory, before treatment, the drug is in the circulation, and after treatment, you could see the antibodies binding to the drug in question and creating the inactivation. There are very few studies, but they're beginning to emerge. Here is one such study, and the results of the study showed that there was an elevation in antibody levels and was associated with significantly reduced cocaine use, but only 38% in this particular study of vaccinated subjects achieved the antibody levels that they had only 2 months after adequate cocaine blockade. So the point here is that it's starting to emerge. I don't think this is going to go away. I think you're going to see more and more of these kinds of studies. This is an imaging study showing that if you, with this particular immunization strategy, that after immunization, you can see evidence for blockade and a normalizing of this is before, this is no cocaine, with cocaine, but after immunization, and you can see that the striatal dopamine, in this case, dopamine receptor sites, are not quite normalized, but getting there after the antibody treatment. So summary, it's the second last slide. Pharmacotherapy development strategies build on on neuroscientific knowledge of reward systems. I would say that there are limited new pharmacological targets in recent years. Their efficacy has been modest. These existing therapies target systems that actually have been known for some time. I would say the NMDA, AMPA, the glutamate systems, and nicotine-based treatments are the most recently emerged, but they've been around for some years. So the point being that really new developments in terms of that approach have not been seen in the last few years. Immunotherapies are the most recently explored emerging target and really do represent a paradigm shift. Additional considerations, that it just speaks to the point that I made earlier, that we know a lot about the developmental trajectory of addiction, and I think we need to think about how do we align our clinical trials and our clinical testing strategies to incorporate that knowledge into our approach, and that's why I highlight developmental pieces here, as well as the importance of individual variability, and can talk about some of this more during the question period. Thank you.